All right, welcome. Our first speaker today is Dr. Anthony R. Gregg. Dr. Gregg is the Chief of the Division of Maternal and Fetal Medicine in the Department of Obstetrics and Gynecology at the University of Florida College of Medicine. Dr. Gregg?
Thank you very much, Dr. Watson. I appreciate the opportunity to speak to everybody regarding next generation sequencing in the evolution of prenatal screening. I have no disclosures to make, and I'd like people to realize that I do have specific objectives for this talk. One is to appreciate that new technologies are challenging prior paradigms in prenatal screening and diagnosis. This is the overarching theme of this talk, and more specifically, I hope the listeners will understand basic elements used to evaluate screening tests and identify those that are important in the pre-test compared to the post-test environment. I would hope that the listener is also able to define residual risk and recognize how adding pathogenic variants to screening panels impacts residual risk. Now, what we all recognize as obstetric care providers is that throughout pregnancy, there's an enormous number of screens that are performed. Screening in pregnancy simply refers to the application of laboratory or clinical methods and technologies in an effort to identify risk of unexpected outcomes. When the same labs or tests are applied to those with a family history or those known to be at high risk, the term screening is not usually used. This becomes sort of an indicated testing view. Colonoscopy on patients that are known to carry a gene which causes HNPCC, for example, compared to patients with no family history and considered average risk. Colonoscopy in that patient with HNPCC, for example, is really outside of the type of screening that's performed throughout pregnancy. Now, there are several examples of screening in pregnancy, and those are shown in yellow on this slide. Prenatal laboratory tests that are performed at the very first obstetric visit are just one example of pregnancy-related screening. Throughout this screening, we can identify patients who might be at risk of having a hemoglobinopathy. We're looking for anemia, for example. Many of the screening laboratory tests are looking at predisposition or already established infectious disease and how that might impact pregnancy. And of course, we perform the well-known screening test called a pap smear in early pregnancy. Likewise, ultrasound is used as a screening tool. It's a screening tool for birth defects in the second trimester of pregnancy. And we've learned over the past 10 or 12 years that ultrasound performed in the late first trimester and early second trimester can give us a clue that aneuploidy might be present in an ongoing pregnancy, and can also give us a clue that heart defects might be present or other structural malformations might be present in a developing fetus. Serum analyte screening has been around for a long time. Initially, a screening test for open neural tube defects, later a low maternal serum alpha-fetoprotein identifying patients who might be at risk of carrying a fetus with Down syndrome, and then this evolved wherein analytes were added so that the biochemical test, now known as a quad screen applied in the second trimester, is used to screen for fetal aneuploidy. And in fact, in the first trimester, when that quad screen is added to first trimester ultrasound and additional analytes, the detection rate for aneuploidy increases significantly. This slide is used to depict and make sure that the listener understands that there is a distinct difference between diagnostic testing and screening. And on the left side, you'll see that there are new technologies that are used in prenatal medicine, perinatal medicine today, on the diagnostic side and on the screening side. Array technology has been around the longest. Array technology takes advantage of the application of bioinformatics to make diagnostic, to allow for prenatal diagnoses. On the right side of the screen, we see that screening today is utilizing next-generation technologies in combination with bioinformatics to allow us to take advantage of screening for aneuploidy in the case of NIPS, or non-invasive prenatal screening, and on the far right, in the example of expanded carrier screening, we're also able to apply this technology in an effort to identify pregnancies at risk for what might be described as single gene disorders. Please be aware that both of those technologies on the right, the application of next-generation sequencing for aneuploidy detection or for expanded carrier screening, are non-invasive. Either of these could lead to the need for an invasive screening procedure. And that one on the far left, again, array CGH, is diagnostic. The hope overall is that these non-invasive approaches will become increasingly close to what is achieved through invasive diagnostic testing. Now, next-generation sequencing technology was made possible by the advent of massively parallel sequencing. In other words, if we see on this slide, in the early 80s and early 90s, gel-based technology for sequencing was quite costly, estimated at approximately 10 cents per kilobase. As we've increased our technologic capability, we've gone through what was traditionally Sanger sequencing on the far left, which had a slow turnaround time and high cost per nucleotide, to what is now a much cheaper platform that allows many more sequencing read, thus increased fidelity and high throughput, and thus the capability of screening larger number of patients over shorter time periods. Note the steepest point of the curve represented by the past 10 years. The term deep sequencing refers to the ability to perform repetitive sequencing runs at low cost over short time periods in an effort to improve fidelity. I want to use expanded carrier screening as our launching point here to understand some very basic concepts in screening. Expanded carrier screening is the utilization of next-generation sequencing technology and bioinformatics to identify carriers of disease, associated alleles for multiple conditions simultaneously. Please note, however, and we'll emphasize this one more time later in the talk, that these conditions are not always recessive conditions, and this adds to the complexity in the counseling that's required around expanded carrier screening. But in general, you can think of expanded carrier screening as multiple genes, multiple alleles, and multiple conditions being investigated simultaneously. The term multiple causes me to bring up the concept that this sequencing technology, this prenatal screening approach, was first utilized in the reproductive endocrinology and infertility clinics in a way to provide reassurance to those patients that might be undergoing donor gamete fertilizations and other assisted reproductive technologies. So expanded carrier screening is an interesting approach to providing information to couples either in the preconception period or applied early in pregnancy. Clearly, the preference is to perform this type of screening in a preconception environment, as sometimes, as you'll see going forward, that there are additional steps and the counseling required can take some time before couples can reach decisions related to fecundity and future pregnancy. Expanded carrier screening, we all recognize, has the same opportunity as cystic fibrosis to provide information to couples in a sequential format or simultaneously. The sequential approach refers to the idea that we would screen first the female as part of this couple, and then we would move forward and, depending on the results obtained, After screening the female, we would screen the male. Simultaneous screening refers to screening the couple at one time and then establishing a risk of an affected fetus over a shorter time frame. There are advantages and disadvantages of either approach, and we won't go into these in much detail, but I think we all recognize the advantages and disadvantages when we think of single gene screening, such as has been performed for cystic fibrosis and spinal muscular atrophy. Well, these are the types of results that can be obtained after screening. You can clearly have a couple that has no identifiable sequence variants in any of the conditions identified. It's important to tell couples that this is unlikely to be the case because many of us will be identified. In some studies, it's estimated that half of all couples screened, half of individuals screened, will have a sequence variant identified. Certainly, the female can have a sequence variant identified and the male not. The opposite could be the case where the male has a sequence variant and the female not. And we can also have a case where each of the members of this partnership have a sequence variant, but not a sequence variant involving the same gene. And an example is shown on the bottom right, where the couple each carries a sequence variant within the same gene. This would be the couple in this setting that would be at greatest risk for having a fetus. In fact, 25% if we're talking about a recessive condition of having an affected fetus. It's important, and we'll go into this in much greater detail in this talk, that residual risk is understood in the counseling discussions. What this refers to is the risk of still being a carrier after receiving a negative result. So in each of these cases on the left, there is residual risk identified. And make no mistake that since there are so many conditions being screened for, those couples on the right, although they are identified with sequence variants in specific genes, they can also have residual risk for other conditions for which they tested negative. There are additional struggles that surround expanded carrier screening, and that is the concept that couples understand there is a 25% chance of having a fetus affected by a specific condition that they both test positive for. And the identification of the fetus requires invasive testing. When invasive testing is performed, sometimes very rare alleles are required for testing. Remember that in expanded carrier screening, we are screening for multiple alleles, not just a small panel, but in some cases more than 100 different variants within one gene might be screened for. It might be very difficult to identify a specific laboratory capable of testing a fetus, handling amniotic fluid samples, for example, and then testing for very rare alleles. So there is a time element here in the case where sequential screening is applied in early pregnancy. There are certainly challenges with regards to pre-test counseling on the left and post-test counseling. And then there is cost of expanded carrier screening that needs to be taken into consideration. And we won't dwell on the aspects of cost in this discussion today. So what did we learn? What can we take away as far as a historical perspective on expanded carrier screening? And this slide harkens back to the mid-1960s, where Wilson and Jungner presented to the World Health Organization concepts surrounding the principles and practice of screening for disease. It's important for the listener to recognize that screening at this time was largely focused on infectious disease and some of the chronic diseases that were potentially treatable. But there were three general categories shown on this slide: the condition itself, the test itself, and the social aspects of testing that were relevant or put forth as being highly relevant to the World Health Organization. Number one, is the condition important? Number two, what's the natural history of the condition? And is this natural history well understood? Is the condition detectable at an early stage? And there should be early stage treatment, which is of benefit to patients if a screening approach for disease is applied. Now you can imagine that in an expanded carrier screening context, that conditions might be deemed important or unimportant in certain contexts, and that the importance of a specific condition, a specific genetic condition on a panel might be deemed unimportant to some, but important to others. You might also understand that the natural history of some conditions, for example, very rare genetic conditions, might not be well understood. Certainly, the opportunity to do genetic testing is the opportunity to detect and understand conditions at their earliest stage. Early stage treatment should be of benefit. This is true of some conditions on expanded carrier screening panels, but not all. With regards to the test itself, is the test suitable for early detection? Certainly that would be the case in genetic testing for many of these conditions. But keep in mind too, this means that the alleles being tested for are clearly linked with the phenotype. And we have to ask ourselves, as we'll talk about later, what is our understanding of that linkage between the genetic variant and the phenotype itself? Is the test acceptable? Certainly a blood draw for the identification of the patient's genomic predisposition for disease is certainly an acceptable approach. Is there a need for repeated screening? There is not a need typically for repeated screening in the case of carrier screening for couples, because once that couple is screened, especially in the expanded carrier screening environment, there's not likely a need for repeat screening. Socially, the test should be, we should understand the impact the test has on adequate healthcare supervision and the need for extra clinical workload. I mentioned that pre-test and post-test counseling will need to be performed. You can imagine that this puts a heavy burden on trained genetics counselors, and then there is a requirement, therefore, that all obstetric care providers have some ability to talk to patients about the pre-test and post-test counseling elements that are required. The benefits of the screening should exceed any physical or psychosocial risks. There's a paucity of information on expanded carrier screening with regard to this, but certainly the psychosocial aspects, anxiety and guilt attached to patients who are carriers of conditions has been explored in the example of single gene screening approaches. Costs need to be balanced against the benefits, and there is certainly a lot of discussion had right now regarding the application of expanded carrier screening and non-invasive prenatal screening for fetal aneuploidy and how that will impact the cost of providing routine pregnancy care. Well, we also took away from Wilson and Junger in the 1960s that multiple screening has been defined as the application of 2 or more screening tests in combination to large groups of people. The procedure has evolved by combining single screening tests, and it's the logical corollary of mass screening, not only bringing in large numbers of patients at one time and screening for a single condition, but when you have these large number of patients that you're trying to apply screening tests, apply the greatest number as possible. It's natural to consider the economy of offering other tests at the same time, and that's in essence what's being performed in expanded carrier screening. Again, multiple genes, multiple alleles for multiple conditions. The Commission on Chronic Illness sort of provided the background for some of the Wilson and Junger criteria, and they pointed to the value of multiple screening as contributing to good medical practice, and that it was a practical means for early detection of a number of important chronic diseases and impairments. Some of those conditions are shown on the right side of this slide. note that other than the infectious diseases shown here, expanded carrier screening and an exploration of genomic predisposition impacts many of the conditions important in the 1950s and 1960s. Now, perhaps the greatest success in expanded carrier screening or expanded screening in general is that of newborn screening. Currently, 31 conditions are on the panel, the minimal panel of conditions today. And you can see in this slide that these conditions explore the gamut of possible conditions that the newborn can be screened for: fatty acid oxidation disorders, amino acid disorders, organic acidurias, congenital hearing loss is screened for, critical congenital heart disease, cystic fibrosis, and a number of other conditions that are not necessarily metabolic, endocrine disorders and hemoglobinopathies. Importantly, though, newborn screening is looking at a gene's protein product or function and how those functions impact a specific pathway. Therefore, metabolites are often the analyte screened for. And so one of the distinctions here is that in expanded carrier screening, we are looking at the nucleotide sequence that impacts the protein, that protein product or function and pathway metabolites. So we're performing this earlier in the evolution of a phenotype, if you will. On this slide, those conditions shown in red are on expanded carrier screening panels. It's important to understand that maybe performing expanded carrier screening could result in some cost savings at a state level as well, since this would only have to be performed once per couple. If we look at how specific professional organizations have applied single gene screening, we take away some important messages. You'll recall that ACOG weighed in the early 1990s and said that patients with a family history should be tested or screened, was the terminology used at that time, to determine whether or not they were carriers of cystic fibrosis. In 2001, the same professional organization commented that Caucasians and Ashkenazi Jews should be offered the opportunity for carrier screening for cystic fibrosis, and it should be made available, meaning that a pamphlet should be provided to patients who were of other racial ethnic groups. In 2005, the appreciation that it becomes very difficult to screen patients of specific ethnic groups, and so the concept was that because of so much racial intermarrying or racial intermixing, that cystic fibrosis carrier screening should be offered to all patients considering a pregnancy or in early pregnancy. And then the concept in 2011 that OB care providers should review the prior tests that might have been performed in patients so that repeat testing would not be necessary. ACOG weighed in at that time that sequencing should not be performed, and that newborn screening was not the same as carrier screening for cystic fibrosis. The American College of Obstetricians and Gynecologists also weighed in on an Ashkenazi Jewish disease screening panel, citing in 1995 that Tay-Sachs screening should be performed for all patients who self-identified out to a third generation relative that there was Ashkenazi Jewish descent in the family. Likewise in 1998 for Canavan's disease. And in 2004, the concept was that screening for four conditions, Tay-Sachs, Canavan's, cystic fibrosis, and familial dysautonomia ought to be offered to patients, and patients should have available to them or be offered the opportunity to have additional disorders screened for mucolipidosis type 4, Fanconi's anemia type C, Niemann-Pick, Gaucher's, and Bloom's syndrome should be offered to those patients. You'll notice that the number of conditions has increased from 1995 to 2004 and 2009 due to the Human Genome Project. ACOG suspected that the number and choice of conditions was likely to increase. What you're seeing here is the concept that we're seeing in expanded carrier screening. That is no more self-identification, making the conditions that are on expanded carrier screening offered to all patients, and now we're expanding conditions and expanding alleles. So there is this natural progression to an expansion of condition and alleles as we've seen over the last 20 years or so. In summary, history provides a precedent for expanded carrier screening, and that's what the expanded carrier screening now in the prenatal setting is providing as a base. Now what about screening test metrics? It's really important for care providers in the obstetric setting to understand the screening test metrics that are applied. So on the top right of this slide, you'll see that in this case, we're going to look specifically at, let's just say, a single gene condition. We're trying to identify in the carrier screening environment whether that variant is present or not present, or whether a series of variants are present or not present, say any of the mutations known to cause cystic fibrosis. We have a test, a typical test for cystic fibrosis, or a small panel looking at very common mutations, let's say, and we're trying to determine how that test functions. On the left are those patients that test positive or those patients that test negative. You can see that TP refers to the true positives, FP for the false positive, FN for the false negatives on the bottom left, and on the bottom right, true negatives for those that test negative. Now, in the pretest counseling environment, patients are interested in detection rate. They are interested in whether they are amongst all of those patients in the denominator that carry the variant, or in this case, cystic fibrosis. How well will that test do in identifying them or detecting them as a carrier? In this column, they are also interested in the concept of whether this test performs in a specific manner, meaning of all the patients that don't have a variant, will this test really identify them as being a patient that then does not have the variant? So in the pretest counseling, patients are worried about the sensitivity of the test, whether the test performs well in terms of detecting the condition, and they're also concerned about whether the test can be relied on with regards to specificity and telling them that they are amongst those that do not have the condition or the variant present. In the post-test environment, patients are given information. They are told that they have tested positive or that they have tested negative. And now they are interested in this portion of the table. They want to know whether they are in fact true positives or whether they are false positives. They're interested, therefore, in the positive predictive value. They're also, if they're given a negative test result, interested in the negative predictive value. Are they truly negative? How likely is it that they are a false negative? Residual risk will be talked about in this context as well, but keep in mind that a diagnostic test generally has no false positives, so that the positive predictive value is 100% in the case of a diagnostic test, and screening tests are often compared to diagnostic tests in terms of their efficacy. In the case of residual risk is defined as 1 minus the negative predictive value. If the negative predictive value is 100% or 1, the residual risk is 0. It means that this test performs perfectly with regards to the negative test result that a patient might receive. And so you can see that in genetic testing, in specific carrier screening, where a limited number of mutations are searched for, there will be a residual risk, because we're not telling all patients that they are negative for all possible mutations when we screen for a specific condition. And so residual risk will never be zero. Let's talk a little bit more about residual risk, and let's try to understand what are the determinants of residual risk. First, we must know the carrier frequency in a population to be able to calculate residual risk in genetic testing. And for many of the conditions, but not all the conditions on expanded carrier screening, we know the population carrier frequency. It would also be should also be understood that detection rate should be well appreciated, because 1 minus the detection rate times the carrier frequency determines the residual risk. In this example, a population, a Caucasian or Ashkenazi Jewish population, in this case we'll use a Northern European Caucasian population, will have a 1 in 29 carrier frequency for cystic fibrosis. The common mutation panel recommended by the American College of Medical Genetics and Genomics has a detection rate in this population of 90%. Thus, the residual risk is 1 in 290 from its starting point of 1 in 29. This slide shows the carrier frequency for those Ashkenazi Jewish conditions that the American College of Obstetricians and Gynecologists recommended for either testing or offering the test in the Ashkenazi Jewish population. And I want you to appreciate that from this slide we can apply those same mathematics and try to get at residual risk. And you'll see that depending on the detection rate and the risk left over after that detection rate, that 1 minus detection rate variable in that equation, you can have widely variable residual risk, even for common conditions. In this case, the residual risk is 0.03, or is 0.03, and can go as high as 0.006 in the case where the detection rate is very high. Let's say there's 90% detection. For very rare conditions, we wind up with a detection rate of 0.004 for a test that's only detecting, let's say, half of the possible alleles that lead to the disease. And in this example, when you reach 90% detection, 0.0008 is the residual risk. And you can imagine then that the spectrum falls in between these numbers for any of the other conditions on a panel such as this. Now, you'll look at this and notice that the carrier frequency in a population impacts greatly the detection rate, so that, it impacts greatly the residual risk. And the reason for that is that this carrier frequency, when it's very low, will result in a very low residual risk even before testing. So that a test may not have to be very good in terms of its detection rate for that residual risk to be low, but that's because your starting point was very low in the first place. And that's an important concept to recognize with regards to expanded carrier screening. This slide shows data from a paper recently published in Genetics in Medicine, September 2012. In this paper, approximately 23,500 patients were screened for 96 conditions. Mild conditions were excluded, specifically those with high allele frequencies and reduced penetrance. On the right of the slide, one can see two columns, the published carrier frequency and the carrier frequency identified after screening multiple genes for multiple alleles. What is particularly striking is that for many of these conditions, the published carrier frequency is much lower than the carrier frequency identified after expanded carrier screening panels were applied. This might represent one of the observations and concerns surrounding expanded carrier screening, and that is whether or not the alleles or mutations being screened for are really disease-causing. This is showing you detection rates for those same Ashkenazi Jewish conditions after DNA testing, and I want to point out here that detection rate is high in isolated populations. You saw on the previous slide that those detection rates were above 90%. They were 95 to 99% in some of those cases due to the founder effect. Well, historically, we've chosen 90% as a detection rate. That detection rate is arbitrary, and in expanded carrier screening, we don't very often achieve a detection rate as high as 90%. In fact, for many of the conditions, the detection rate is thought to be around 50%. But when we're screening in an unselected population, the detection rates are variable and depends on the number of mutations evaluated. That example is shown here in a study that was published in Clinical Chemistry in 2001. About 360,000 patients without a family history were screened for cystic fibrosis using 98 different mutations or sequence variants. And if we apply only the 23 mutations to those 360,000 patients, you can see what the detection rates are shown here for several different ethnic groups across the top right of this slide. This shows you the historic carrier frequency. This shows you how these 23 mutations led to detection for these racial ethnic groups. If you apply additional mutations from the 98 mutation panel, you can see that you can pick up an additional 9% of patients in the Ashkenazi Jewish and Caucasian population, 9% for the Caucasian population, 13% for the Ashkenazi Jewish population. 34 mutations will allow you to identify 27% more of Hispanic patients. 28 additional mutations allowed you to detect 23% more patients in the African American group, and there was an additional 37% detection when 15 mutations were applied to the Asian population. So you can see that detection increases when you add an additional series of mutations. If we go back to this slide, that same table that we looked at earlier, it turns out that instead of telling a patient or instead of having a negative test, we will have more false negatives if we have fewer mutations on a panel. So that term C is important when we're trying to look at the negative predictive value or residual risk. Fewer mutations means that C increases, and so that the negative predictive value will decrease because the term C is in the denominator. That negative predictive value will decrease as fewer mutations are on a panel. So what do we see with expanded carrier screening? We see more mutations on panels, and our negative predictive value will generally increase, and residual risk will go down depending on whether or not those mutations really do cause disease. So in summary, concerns surrounding residual risk can be overcome. We can increase the detection rate by increasing the number of credible sequence variants reported. And on the patient side, it's always important to add to our counseling that expanded carrier screening and screening in general in the prenatal environment is not the same as making a diagnosis. And it's critically important that patients understand that screening and diagnostic testing are different. Well, on expanded carrier screening panels, we have conditions that have a variable disease severity. They are conditions that might express themselves in the early neonatal period or newborn period, to early childhood, to the adult time period. And we have conditions that have variable expressivity, some with severe phenotypes and some with less severe phenotypes. And to understand the importance of these conditions and how they impact patient choice, we have to recognize that the tests and panels applied are identifying specific types of genetic variation, and that this genetic variation on these panels is diverse. These panels look for Mendelian conditions that are recessive by their nature, and also on these panels are semi-dominant and dominant conditions, so that we're identifying potentially affected or affected individuals as well, and maybe they're pre-symptomatic. On these panels we see as well trinucleotide repeat disorders. My point here is that there is a diverse group of genetic variation that we're testing for on expanded carrier screening panels. And just as this is diverse, this molecular mechanism for disease is diverse, we can also anticipate that disease severity will follow and fall into some spectrum to be what might be called diseases or conditions with a minimally severe phenotype to those with a very severe phenotype. And it's difficult to know exactly how patients perceive the disability after some of these conditions. Some of these conditions will fall along the spectrum of neonatal onset to late adult onset, and likewise expressivity might be variable or mild and might be variable to severe. And again, this is a difficulty in expanded carrier screening because it challenges us to no longer think of conditions as categorical, but we now are thinking of conditions as having a spectrum. It was much easier from a screening approach and counseling approach to tell patients that they carried a mutation for a condition such as cystic fibrosis that was going to definitely have a phenotype that was severe. We know now that we have on the expanded panels genetic sequence variants that might be much more variable in their presentation, their onset, and their expressivity. Well, expanded carrier screening, again, was first implemented in the reproductive endocrinology infertility environment or assisted reproductive technology environment, and pre-implantation genetic diagnosis took over as the genetic laboratories in this area. But I want you to appreciate from this slide that there is a difference between secondary prevention and primary prevention, and expanded carrier screening plays a role in each of these. Secondary prevention aims to discover and cure conditions which have already produced a pathologic change, but which have not so far reached a stage at which medical aid is sought spontaneously. In the 1960s, Wilson and Younger proposed that the idea of screening had a place in secondary prevention and primary prevention. On the right of this slide, we can appreciate that when there's an established pregnancy, secondary prevention might be most applicable, and certainly newborn screening has its place in secondary prevention. Primary prevention seeks to abolish disease by protecting the individual and the population from attack before the challenge has been made. And in expanded carrier screening, when we identify preconceptionally at-risk couples, we have the opportunity to apply primary prevention techniques, and I'll get into these. But let me show this again graphically, what is primary and secondary prevention. I mentioned that newborn screening is an example of screening an affected. It's screening a protein product that's in the serum of the fetus, or a metabolite that's part of a metabolic pathway in the fetus, or it's screening a condition. In the case of hearing loss, it's screening the function of an organ directly. In the case of screening for carriers, such as expanded carrier screening, we have the option of implementing this in the preconception time period, sometime between conception and typically between 20 weeks gestation, when carrier screening is often applied, but we have an opportunity here of learning at a much earlier stage in development or preconceptionally that a couple is at risk. So keeping this thought in mind that primary prevention aims to prevent occurrence of condition, secondary prevention aims to make early diagnosis a possibility so as to offset morbidity, some patients, we must remember, will prefer primary prevention strategies, and these patients need to define the starting point at which they consider primary prevention to be defined. For example, in the case, some couples might define primary prevention as the prevention of a conception. Some other couples might define primary prevention as aiming at preventing the birth of a child with a specific condition. And what's available to patients in the first case, where primary prevention is thought by that couple to be prevention before conception, they have the option of donor gametes. So expanded carrier screening can screen individual donors to determine whether or not they are carriers. In the case where a couple views primary prevention as the prevention of the birth of a child with a specific condition, they have the option not only of donor gametes, but they have the option of pre-implantation genetic diagnosis, where the conception has occurred in the case of assisted reproductive technologies, and now specific blastocysts are tested so that only blastocysts that are not affected would be put back into the uterus to allow an ongoing pregnancy. And certainly primary prevention for these couples might be cases where the fetus is identified to be affected, again a 25% chance that both the members of the couple are carriers of a condition, so pregnancy termination would be an option for those families. And again, this is the primary prevention model. Now, the idea of secondary prevention is an interesting one, because many people would say that expanded carrier screening then has no place for those couples that are interested only in secondary prevention. But we must remember that while pregnancy termination may not be an option for those couples who prefer to look at expanded carrier screening as a secondary prevention approach, they are, by having been identified as an at-risk couple, they have the option of testing that pregnancy and obtaining specific patient information that might teach this couple before the birth about the dietary interventions that might be applicable for their future child, the surgical intervention or medications that might be needed, and they also have the opportunity to learn more about the prognosis and specific medical and social needs that that child will have after birth. They, in essence, also are given a huge advantage of avoiding the diagnostic odyssey through the healthcare system in knowing that their child is affected before the birth of that child. So next generation sequencing technologies with high throughput allow us to expand our prevention strategies for more conditions. So I would like to shift gears and be sure to cover a little bit about non-invasive prenatal screening for fetal aneuploidy. This is a screening test, which means that the test is known to have false positives and false negatives associated with it. The test relies on placental-derived cell-free fetal DNA that circulates in the maternal bloodstream. Some people have described this as being a holy grail of sorts, in that the access of fetal DNA non-invasively through a maternal blood draw has the potential to allow for the evaluation of any portion of the fetal genome at will. This slide shows the high-risk patient population deemed by the American College of Obstetricians and Gynecologists to be appropriate for non-invasive prenatal screening. Maternal age 35 years or older at the time of delivery. Fetal ultrasound findings indicated an increased risk of fetal aneuploidy. History of a prior pregnancy with a trisomy. having had a positive test result for fetal aneuploidy, including first trimester screening, sequential or integrated screening, or the quad screen, parental balanced Robertsonian translocation with an increased risk of fetal trisomy 13 or 18. These high-risk patients this list of high-risk patients can also be seen if one reviews the literature leading up to non-invasive prenatal screening. Fetal cells in maternal circulation were studied in the NIFTY trial, and it was exactly this patient population that was used for study. Keep that in mind as we look at this table once again. The non-invasive prenatal screening approach for aneuploidy, as I mentioned, does have false positives and false negatives associated with it. False positives are derived from placental mosaicism, vanishing twins, or DNA from other sources than the genomic DNA of the mother or the genomic DNA of the fetus. For example, a mother with cancer might have a DNA source circulating in high enough concentration that this can be picked up on the non-invasive prenatal screening platform in use. False negatives derived from reduced cell-free fetal DNA fraction. This can occur because the gestational age is too early. Typically, at least 9 to 10 weeks is required, or in obese patients who, for reasons that are not entirely clear, are sometimes determined to have lower cell-free fetal DNA fractions than patients who are not obese. Recall that positive predictive value is one of the screening test metrics that is influenced by population prevalence of a condition. By screening the high-risk patient groups that were depicted on the last slide, and now making an effort to apply non-invasive prenatal screening to average risk patients, there is some concern that positive predictive value will be reduced in doing so. So if we look at the variables that determine the positive predictive value, what we're saying is that in low and average risk patients, the true positive number will decrease, and the false positives are anticipated to stay the same in this patient population, or in fact increase. If this is so, the positive predictive value, because the true positive number decreases, will in fact fall. Well, it is unclear whether or not this will be an order of magnitude significant enough to cause one to be concerned about the utilization of non-invasive prenatal screening in low or average risk populations. One reason for this is that the mechanisms behind the false positive rate could also potentially change with maternal age. For example, placental mosaicism and twinning are or would be perhaps predicted to be lower in patients of lower or average maternal age compared to those that might be over age 35. And certainly mechanisms that cause cancer and the presence of cancer in a mother might be anticipated to be lower in those patients of a younger age. So the information still not available to us is a large study of non-invasive prenatal screening in an average or low-risk population. One trial is underway, and data are anticipated in the near future to tell us how NIPS will perform with respect to the positive predictive value. With regards to NIPS and detection rate, as well as specificity, you can see that for both, these are 98 to 100% for trisomy 21, and certainly approach 98 to 100% for trisomy 13 and 18. In summary, next-generation sequencing technology is challenging long-standing paradigms in prenatal screening. Specifically, movement is away from condition-by-condition screening because more information is provided, and the need for residual risk becomes less important as we add more conditions and more variables to the screening platform. Screening strategies can approach diagnostic testing, as was seen in the previous slides. The challenge for providers is not how to deal with next-generation sequencing, but how to manage the information it brings to patients. Specifically, pre-test and post-test counseling are clearly going to change from the condition-by-condition approach of the past to a more expanded approach in the future. Thank you.
All right, thank you, Dr. Gregg. That overview of our prior approaches to both prenatal and perinatal screening nicely sets up our next talks in this webinar. Thank you.